Okay, thank you for joining this webinar, and I want to thank also GMDD and Damon for the kind invitation. We will talk about AVNeo procedure, Ozaukee procedures versus the ROS procedure. This procedure can be or complementary to the ROS procedure. 20% of the patients that are every year operated for aortic valve replacement are younger than 60 years. The ROS procedure is applied only in less than 3% of the patients, along with homografts. But if we look at the results, we can see how the ROS procedure provides the best result compared to the mechanical valves or to the biological valves. This is in terms of long-term survival, but also in terms of valve-related events like bleeding, thromboembolism, or endocarditis. This is from the AVNeo registry, but these data are confirmed by many studies, retrospective, prospective, randomized trials, and meta-analysis. Despite these good results, the ROS procedure is not mentioned in the last European guidelines and is considered in US guidelines only for patients with contraindication to anticoagulant therapy. This is one of the last and most complete meta-analysis that was published, and we can see that the patients who undergo to a ROS procedure, in these patients, the survival is equal to the survival of a sex and age-matched population. On the other hand, we have, in any case, a high incidence of right and left side valve degeneration that is really high in young patients, younger than 35. So patients younger than 18 will experience 100% of degeneration on both valves, but the rate of both valves degeneration remains really high, under 40 years of age, but decreases with age. Despite these good results, there are only few centers with a consistent experience in ROS procedure. We can see that also in high experience centers, their series are not so big. I mean, we have 200, 400 specialists. The biggest experience reported is from Germany, from the German registry, with more than 1,700 patients. So the ROS procedure has 53 years of history, but in the last 2 decades, there were very significant improvements in terms of results in lowering the operative mortality and also in lowering the mortality of reoperation. There are anyway some drawbacks. The first one is that it is a complex procedure. The learning curve is very steep, and also among high experience centers, the number of patients that is on average treated every year is less than 10 patients per year. The results are better for isolated aortic stenosis, are worse in patients with aortic insufficiency. This is because the pulmonary autograft is just one size, so it is difficult to adapt in a dilated aortic annulus or aortic root. Also, the availability for allograft is not so simple. There were recently restrictions in harvesting and banking of cadaver tissue. In many countries, there are not homograft banks, and cadaver tissue is not considered for ethic or religion reasons also in many countries. And there is still the problem of the degeneration of both valves and the complexity of an eventual reintervention on right and left valves. This is the flowchart, an algorithm that was recently published by Mazin and Yacoub that highlights the advantages and the pitfalls of this procedure. We have excellent long-term survival, excellent quality of life, avoidance of anticoagulation, superior hemodynamics, and low rate of valve-related complication. But the main pitfalls are the technical complexity, the potential long-term failure of both valves, and the complexity of reoperation. So the ideal candidate is a patient with a small aortic annulus and with an aortic stenosis, and the procedure is more complex among patients with aortic insufficiency and mixed lesions or with dilated a dilated annulus. So, do we have an alternative to the ROS for non-elderly patients, younger and non-elderly patients? Now we have the AVNeo, the Ozaukee procedures. That the aim of the Ozaukee procedure is to combine the advantages of the ROS procedure in terms of quality of life, avoidance of anticoagulation in a low rate of valve-related complications, and of course we hope in a good long-term durability of the procedure. But it is a single valve procedure, so we eliminate the problem of an operation on two valves. The learning curve is for sure easier. It's a more reproducible procedure than the ROS, but of course a training is needed. It is a standardized procedure because we have sizer, templates, metrics, so we have a series of tools that can help us in the procedure. And we use the autologous pericardium. There is no immunogenic response, and we will see after how it can work over time. The autologous pericardium has excellent textile characteristics that are better than heterologous bovine pericardium. And with this technique, we can treat more easily complex aortic valve disease like bicuspid aortic valves and aortic insufficiency. And in case of reoperation, it's just one valve, and we have some surgeons reporting reoperation in failed valves, and they report quite an easy operation in redo cases. So the use of the autologous pericardium for aortic valve surgery is probably old like cardiac surgery itself. The first one to use the autologous pericardium was Ross himself in 1963. It was the year of my birth. And subsequently, other surgeons like Bjork, Edwards, and Yacoub were using autologous pericardium for valve surgery, for aortic valve surgery. Carlos Duran was really active on using autologous pericardium in the early 90s during his work experience in Saudi Arabia. He developed this procedure. He was treating pericardium with glutaraldehyde. He was trimming using these plastic molds to create new cusps on the basis of this sizing scheme. And he was suturing the cusps with a freehand suture to the aorta, creating a new aortic valve. So we can consider this procedure the ancestor of the Ozaukee procedure. What is really interesting are the results reported by Carlos Duran with 60 years of follow-up. He was applying this procedure to young patients. The mean age of his patients was 31 years, These patients were mainly affected by rheumatic disease. And he treated 92 patients, 65 with autologous and 27 with heterologous pericardium. What is really important, we are not to look at the reintervention and the overall results, because most of these patients were reoperated for progression of the rheumatic disease on mitral valve. But what is really interesting is that at 10 years, he was observing a freedom from structural valve degeneration of 90%. In this class, in this age group of patients, really young. And the degeneration of the pericardium started in the second decade. So at 60 years, he has 50% of the patients with the degenerated valve and 50% with the still well-functioning aortic valve. So if we look at these results, these results are not so far from the results that we have with the Ross procedure. So in patients so young, there is a degeneration of the valve treated with autologous pericardium that is quite similar to the degeneration that we have in the same age group of Ross patients treated with the Ross operation. This is another interesting experience that was reported by Chan and Dreyfus, that they developed a symmetric stentless valve, also using a gluteral dye treated pericardium. They have a small series of 11 patients. Some patients were reoperated for endocarditis, one for failure of the procedure, but it was really initial experience. But what is really important is that 7 patients with a follow-up of 8 years are without structural valve degeneration. And another really interesting findings in this series is that this is a leaflet that was removed after 2 years, and it demonstrates that the pericardium heals over time. There is a healing of the pericardium. The pericardium is still viable. It is endothelialized. It is colonized by fibroblast, and the collagen fibers are preserved. He was also reporting this interesting dynamic study with MRI that was showing how all the aortic valve system that is constituted by aortic annulus, aortic root, leaflet, sigmotubular junction, all the movement of this system is preserved using this kind of operation. So basically preserving the movement of the annulus and of the aortic root. The healing of the pericardium was also reported by this Chinese group that was operating basically the same group of patients of Duran, young patients with rheumatic disease, but also in this case, the finding was that the pericardium is still viable, and another important finding was the presence of an elastic lamina in the thickness of the pericardium. That means that the pericardium heals and it adapts to the new environment. So there is an adaptation of the pericardium to the new environment, to the arterial pressure. So let's go to the results of Ozaukee. We can see this is his report for patients younger than 60 years, and he has a freedom from reoperation of 98.9% at a follow-up of 76 months, so at 6 years. And this is the last paper that was published by him. It's just a commentary, but he is reporting 1,100 patients with up to 12 years of follow-up with the freedom from reoperation on 95.8%. That has really excellent results. But if we look in depth to the results of Ozaukee, those are not so surprising. So the freedom from reoperation at 8 years in 850 patients is 91.6%. If we compare these results with the results reported by Duran in a really young population of 31 years of mean age, we can see that Duran was reporting 90% of freedom from structural valve degeneration at 10 years. And this is a population that is 40 years older than that reported by Duran. So we can expect excellent results at least at 10 years. And we can expect also good results in the second decade. We hope so. Oh, these are the number of cases. This is the number of cases that are supposed to be done until now. So more than 4,300 cases. Half of these cases were done in Japan, 1,100 by Ozaukee himself, and 800 by other Japanese centers. And we have now 108 active centers in the world. And this is the increasing number over time, number of cases treated over time. We have now in the last year, in 2019, 800 cases that were operated with AVNeo procedure. So we said that AVNeo procedure is a really reproducible technique. What we need is just 7 by 8 centimeters of sheet of autologous pericardium, 100 millimeters of 0.6% of glutaraldehyde, and this kit, these tools that contain the sizer and the templates to create new cusps. So what we do is just measure the distance between the two commissures. We do not measure the annulus, we measure the sinuses of Valsalva. So we report the measure, and Professor Chu was rightly pointing out that sizing is the crucial part of this procedure. So we report on the window of the template corresponding to the size that was taken, and we draw the shape of the cusps and the dot line that will guide the suture line. So it is a very reproducible and precise procedure. So the commissures are made with a separate stitch, and the height of the commissures is one of the most important aspects of this procedure, and it requires a really precise assessment. And what we can say is that usually the commissures are 3-4 millimeters higher than the native commissures, and so also the coaptation height is higher than the native valve. It means that the coaptation surface is about twice the coaptation surface of a native valve. The utilization, it means that we can use this technique to treat bicuspid aortic valves. It is probably a more difficult procedure. We suggest to have a certain confidence and consolidated experience with the technique. So it is recommended to begin after having carried out a series of intervention on the tricuspid valves, and we suggest also to be assisted by a proctor for the first bicuspid cases. This is because we have to create new commissures in the aortic wall. So we have to measure asymmetric sinuses of Valsalva in this case, and then we have to calculate the size of the three new symmetric commissures, and we have also considered the depth of the annulus in these cases in type 0 and type 1 severe bicuspid aortic valves. We can also treat very complex aortic valve pathologies. This is a case of a young boy with a complex mixed valve, stenotic and insufficiency with a monocasp valve and an ascending aortic aneurysm. We were able to create a perfect three-leaflet functioning aortic valve and to replace the ascending aorta. So basically we can use this technique to treat all the aortic valve pathologies. These are the results from Ozaukee in treating bicuspid aortic valves. He is not stabilizing the aortic annulus in case of aortic dilatation. He is reporting for annular diameter of about 25 millimeters, no further enlargement over time. So I'm wondering if in really dilated aortic annulus is indicated or not to stabilize the annulus. This is a good question because we are reflecting on it. And this is the experience of Ozaukee in patients that are younger than 60 years. So most of the patients were about 50 years and 40. Really few patients were treated younger than 40 years. So the results are always really good also in this age group of patients. But as I said before, we can expect for sure really good results at least at 10 years. And this is the gradients in our series. We have operated up to now 34 patients in 18 months, and the mean gradient series is 7.18 millimeters of mercury. The take-home message, so the ROS procedure and the option for and non-ambulatory patient, but is still underused. So the Ozaukee procedure may be complementary to a ROS procedure. It means that we can treat a young patient with an Ozaukee procedure and then delay a ROS operation of 10, 15, or maybe 20 years. But it is also an alternative, considering the early results that are really good. It can be considered an alternative to the ROS procedure because it's much more reproducible. It is an easier, a more simple procedure. It is a standardized. We have metrics, templates. We have driving sutures, so it is very easy to learn. And we can create a very well-functioning aortic valve in every non-arrhythmic aortic root, but we can combine also the Ozaukee procedure to a bent procedure. It was done, and also to a David procedure. So the main concern remain the durability of the autologous pericardium. We have seen that in the past it was used. It can ensure good durability at least at 10 years, but we had to wait for longer follow-up, for longer results. But the fact that the pericardium remain viable can suggest alternative treatment alternative treatments to the glutaraldehyde. And we are studying also, we have a research program on alternative treatments of the autologous pericardium. So thank you for your attention, and fight COVID-19.
Thank you, Dr. Albertini. Just one quick question. Can you talk a little bit about some of the results that you've had? I know you've done about 35 cases now or something. Can you talk about your results and what kind of patients you're focusing on, and any of the challenges maybe that you've encountered?
Yes, of course. So we have treated 35 patients up to now. The mean age of our patients is 54 years. So we treated non-elderly patients. In 20% of the cases, we used this procedure combined with other procedures, cabbage, mitral valve repairs, and ascending aorta replacement. Our results are really good. I mean, we have not to reoperate one patient. We didn't have any valve-related complication, no endocarditis, no thromboembolism, and no hemorrhages. So we are really happy with our experience. We were trained directly by Ozaukee. Ozaukee went after 6 months in our center to supervise our early activity. So probably we will extend the indication to probably all non-elderly patients. My main downside is that we are a center, high volume center for minimal invasive cardiac surgery. That it means that 100% of our patients that are operated for aortic valve replacement receive a minimal invasive procedure. So actually, I need to do a first sternotomy to all the patients we are treating for the Ozaukee procedure for the AVNeo. So we are studying, we are considering also some technical refinement to perform this procedure in a minimally invasive way.
Okay, great, thank you. So we had a couple questions that came in. So middle-aged patients around 40 years old that are not desiring to take Warfarin, anticoagulation, would you recommend a Ross or an AVNeo?
This is a good question. So we don't do Ross, and sincerely, in Italy, there are really few centers doing Ross procedure. Probably I will recommend now at 40 years an AVNeo, because I can expect a durability of the aortic valve reconstruction of about 20 years.
Okay, great, thank you. Another question, can you go with AVNeo for a Bental's procedure?
I didn't do this. I'm thinking to do it, but I didn't do it.
Okay. So another question just came in. What kind of myocardial protection do you use during the Ozaukee procedure?
I routinely use the custodial cardioplasia.
So you're using the crystal clear cardioplasia. Yes. How often are you refreshing? Every hour?
No. Just one shot. It's up to 3 hours.
Up to 3 hours. Okay. Okay.
Our mean cross clamp time is about 120 minutes.
Okay. There's a question. about, so what is your opinion on Tavor in the long term for a diseased AVNeo?
Who?
So, valve AVNeo valve.
So this is a good question. I mean, so valve in valve is proposed for prostheses that are implanted in young patients. It may be also an option for patients with an AVNeo. The only concern we have is the height of the leaflets. I mean, the leaflets are very high. So I don't know if we can have some interference with the coronary ostia, because the leaflets are higher than the native valve leaflets. Probably we have to create some models and to check on models. I mean, we can probably create some model with some 3D printer and to reproduce the AVNeo on models and to check the feasibility. Otherwise, there are techniques, new techniques like the basilica technique that allows to cut the leaflets and to implant it. Yes, maybe it will be possible, but I don't know exactly.
Yeah, we know there's been one reported case so far that's been published out of the group in Japan where they actually put the Tavor into the AVNeo valve. But that's all that I've seen thus far.
Yes, it is interesting because it is also the only one reported case of SVD, or structural valve degeneration.
Yes, exactly. He doesn't report too many failures of the procedure, unfortunately. Okay, we have a couple more questions. Do you think it's possible to use this technique for a quadricuspid valve?
Yes, it is possible. It has been reported also.
Okay. Would be just creating new commissures, right? So it's going to...
Just creating new commissures like in bicuspid or onychast.
Yeah, exactly. Okay, when do you do AVNeo in pediatrics? Let me see. So when you do AVNeo in pediatric patients less than 10 years, when do you expect them to need a reoperation? Okay, that's obvious. I don't. Do you have any? You don't have any experience in that age group. We're going to have Dr. Baird obviously address that tomorrow. Threshold for ascending aorta replacement in patients with non-tricuspid aortic valve disease at the time of Ozaukee procedure.
Can you repeat the question?
Yeah, so what is your threshold for when do you actually replace the ascending aorta when you're doing the Ozaukee procedure?
Yes.
What's your diameter cutoff for the ascending aorta when you would actually replace the ascending aorta as well as do the Ozaukee procedure?
It's about 50 millimeters according to the body surface area.
Okay.
Is the overall indication.
Okay, we have a question. What is your opinion about using the Ozaukee procedure in the pulmonary position?
Theoretically, it is possible.
Yeah, I know that Dr. Sayed, who's on this webinar as well, he's recently done at least one patient with a pulmonary, and I think Dr. Baird from Boston Children's has also tried to do that as well. So
more in congenital, we are mainly treating patients with degenerative valve disease.
Yes. Okay, let's see, a couple more questions. A 3D model of the aortic valve before the procedure, do you think that would help improve your outcomes?
We are creating a program, a research program to create models that we take from the 3D CT scan before, and to see if we can calculate the size of the leaflet in some way. Yes, it's an interesting thing. We are working on it.
Okay. How about, I know we know that Dr. Din and his group, and Dr. Hugh from Vietnam have done kind of a mini sternotomy and a right thoracotomy. Do you think you could do this approach by a right anterior thoracotomy approach, right anterior thoracotomy approach?
So I will want to gain more experience with this procedure, and probably I will do it in the future.
Okay. So let's see, what about doing, I think this from Dr. Garcia, Enrique, it's a bit about the small annulus. Have you done any root enlargements with, you haven't needed that yet?
I think this is a good technique to avoid a root enlargement.
Yeah, I know that Dr. Baird will talk about that tomorrow.
We have a case just very similar to the case that was presented by Professor Chu in a patient, really obese patient, basically the same. I mean, BMI of 42 and an annulus of 21, and we were using Ozaukee in order to prevent a prosthesis patient's mismatch. Exactly as Professor Chu described before.
Yeah, no, that's a
but
good point.
I think this is a good technique to avoid a root enlargement.
Yeah, I think mainly the people that are the patients that we're talking about for the the aortic root enlargement are really the congenital, on the congenital side, the pediatric patients that have very, very small annulus.
No, we do adults, so we do not have experience with the congenital pathologies.
Professor Crane commented to the group that they're doing replacement of the ascending aorta once the diameter hits 42 or 43 millimeters in diameter.
In bicuspid valves?
With a bicuspid valve, yeah.
Yes, maybe we will change, but actually, of course, we can evaluate also the thickness of the aortic wall.
Yes.
Probably the cutoff maybe, so maybe 45.
Okay. And then a question, is it possible to use this technique in aortic valve endocarditis with annulus reconstruction?
Of course, yes. Yes, it is possible. We did it.
Okay, and then let's see. One final comment here. Less aortic insufficiency reoccurrence after arterioplasty for aortic dilation might be due to the STJ reduction and reinforcement.
Yes.
It's more important to deal with the STJ dilation than mild aortic dilation alone. What do you think about that?
So it is possible to do a recalibration of this STJ. Yes, of course. It has been also described how to do it by Ozaukee.
Okay.
The only thing that probably in severely dilated annulus, Ozaukee doesn't stabilize the annulus. So my concerns are only in these cases, but STJ can be recalibrated very, very easily.
Okay, great. Okay, well, we are just about out of time, so I will take the opportunity now. There are no more questions or comments on the group chat to thank everybody for their participation. Thank you very much, Professor Albertini. Thank you to everybody that joined us, and we look forward to hearing from everybody very soon. So thank you very much.